Now in this video we are going to see the interpretation of the white blood cells seen in the complete blood count report. Now the white blood cells can be seen using automated machines, or they can be seen on a manual film examination, where we can see what is the total leukocyte count, what is the differential leukocyte count, that is what are the different type of white cells like neutrophils, lymphocytes, monocytes, eosinophils or basophils are present. The advantage of manual film is that in this manual film we can see the leftward shift. The leftward shift means we see more younger neutrophils like single lobed or bilobed. The neutrophils, you see, they are also called polymorphonuclear neutrophils. They have more lobes as they grow more and more older. So presence of younger neutrophils indicates most likely sepsis. So the manual film is quite useful when you are suspecting that there may be an underlying sepsis causing neutrophilic reaction. Then we see in some reports we see percentages and absolute counts. Absolute counts are more important. They give us a fair idea of what is the actual situation. Are the numbers increased or not increased? We cannot rely on percentages. Let's see an example. We have got a patient who shows a TLC of 6000 per microliter. We see a differential count. Neutrophils 78%, normal is between 42 to 75%. And then lymphocytes, they are 18%, which is normally 21 to 51%. The monocytes, just 3%, and normally they are 2 to 9%. And then we have got eosinophils, which are present in 1%. Normally they are 0.0 to 0.7%. Now, just remember these normal values, they may vary between different labs. So you just consider the normal reference values of the labs which are generating these complete blood count reports. Now, if we see for this example, we see the patient's neutrophil count is 78%. Does the patient actually have neutrophilia, or the patient has lymphocytopenia, or the patient has monocyte normal, or eosinophil count is slightly high? Let's see what are the absolute numbers. Now you see for this same 6000 TLC, the neutrophils in this patient as 78% are 4680, which is a normal count. So the neutrophils can be between 1500 to 7700. So it means this patient does not have a neutrophilia. The absolute neutrophil count is normal. Similarly, patient does not have lymphopenia. The absolute lymphocyte count turns out to be 1080, or the normal count is between 1000 and 4800. So this patient does not have lymphopenia either. When we see monocyte count, it is 180. The normal monocyte count is between 200 to 1000. So this patient may have slight monocytopenia. There is no neutrophilia, there is no lymphopenia, there may be slight monocytopenia. And we see eosinophil count appears slightly high, but when we see this is only 60, which is normal. Normally between 30 to 350 neutrophils are present in the circulation. So you can see the percentages may sometimes be misleading. So see the absolute count of the cells. And then another important thing is when you see a high neutrophil count, what is leukemia versus leukemia reaction? Leukemia reaction is that the WBC count is increased, but they are normal, while leukemia means the blood cancer. So in a leukemia reaction, the lab score is normal. That is, leukocyte alkaline phosphatase score is normal. There is no tissue infiltration. That means the bone marrow or liver or spleen are not infiltrated by these cells, and there may be toxic granulation which can be seen on peripheral film examination. While leukemia, you may have a low lab score, that is leukocyte alkaline phosphatase score. There may be immature blast cells which may be infiltrating into the bone marrow, sometimes into the spleen and liver and other areas as well. So this is what differentiates leukemia from leukemia reaction. Now let's see, it's from a different aspect. In the previous videos, we have seen what are the causes of rise of these different cell lines or the fall in different cell lines. So we are not going to discuss those rise or falls. We see what is the effect or the information we get from the ratios of these cells in conditions which are either non-infective or grossly not inflammatory. For example, a high neutrophil to lymphocyte count ratio. What can we get from this high neutrophil to lymphocyte ratio? For example, this is a predictor of coronary artery disease and a predictor of poor control in type 2 diabetes. So if there is a high NLR, that is neutrophil to lymphocyte ratio, you may predict coronary artery disease, and they may be indicative of poor control in type 2 diabetes. Similarly, this high ratio may be a prognostic indicator in cancers of colon, pancreas, stomach, and lung. And similarly, in studies, an NLR of greater than 4 was associated with a worse solid tumor survival rate. So you see, these ratios can give us information about diseases other than the routine disease we see the white cell counts for. Another example is lymphocyte to monocyte ratio. Lower lymphocyte to monocyte ratio is related with stroke severity and poor outcome. Similarly, a lower ratio is significantly associated with lower overall survival in patients with ovarian cancer and solid tumors. So again, lymphocyte to monocyte ratio can tell us about the idea of what is the prognosis would be in these solid tumors or ovarian cancer. Similarly, eosinophil to leukocyte ratio. Higher eosinophil count and higher eosinophil to leukocyte ratio may be an indicative of coronary artery disease. So it may be seen in coronary artery disease. So you see how these different type of cell lines can be useful in providing us information not only regarding the infective or inflammatory disorder, in non-infective and other type of disorder, these may also be very useful. So this is how we should see these lab reports and make interpretations about the presence of these different type of cell lines.